everyone. I am Gantika, a PhD student under supervision of Professor Chen Zayang from the Department of Psychology in CKU and in Taiwan. So it's my honor to be the host for today's webinar. Today, the talk will be given by Assistant Professor Dr. Wanalee Klomjai, the lecturer from the Department of Physical Therapy, Mahidol University, Thailand. She has great experience in the research about tDCS, and today Dr. Wanalee will give talk about basic principles of transcranial direct current stimulation or tDCS and its application in cognitive psychology research. So everyone, please welcome her. And Dr. Wanalee, please.
Okay, thank you so much, everyone, and thank you so much, Kanika, for the introductions. And actually, I'm not a physiotherapist, so I would like to tell you that I'm not expert in the cognitive domain, but I have used the tDCS for long times since my PhD work in 2011. So it's about 10 years from now that I use tDCS. Okay, so I finished my PhD in neuroscience, and yeah, but when I work here in Thailand, I'm work mostly with stroke patients. Never work with people who have a cognitive impairment except for ADHD patients. Okay, all right, I will start my talk today. So that is the outline today. So I will introduce what is tDCS, a bit of history, animal and human studies, the mechanisms underlying tDCS parameters, and to compare with other brain stimulation technique like RTMS, and also the last thing is tDCS study in cognitive impairment. All right, so transcranial direct current stimulation, trans mean through or throughout or over. So transcranial is a non-invasive stimulations, all right? And the direct current, as you can see in the figure here in the red line, you can see that direct currents, you have no frequency. You have just like a straight, a straight current is a unidirectional flow of electrical charge. All right, so what you need to adjust is just intensity and duration, and also the ramp up and ramp down period. For example, if you see on your right hand side here, you have tDCS from 1 milliampere, and you have a period from 0 to 1 that's called ramp up, and then from 1 to 0 is this one called ramp down. So you just need to adjust the current intensity, ramp up, ramp down, and durations. So again, then no frequency for transcranial direct current stimulations. All right, and tDCS is composed of 2 electrodes, which is anode and cathode. And if you can see in the figure here, is the tDCS nowadays. You can see how small it is, and it has like a built-in battery, so you can carry it with you. It's portable, and the size very small, the weight is light. Okay, so tDCS have 2 electrodes. When you apply 2 electrodes over the brain, so the current will pass between the 2 electrodes, like in the figure here. So this is a top-down approach, and we have been used, the tDCS has been used in psycho and neuro rehabilitation for long times. So we talk a bit about history. Actually, we know the direct current, not transcranial, but direct current, okay? Only direct current is the beginning of 19th century. As in the figure here, you can see that time we apply tDCS like this over the patient scalp, and we use in people who suffer from mental problem and neurological problems. But after that, no one interested in tDCS. But it has been reintroduced again in animal study in the beginning in 1960. And okay, this is one of animal study that I will show to you. So when we talk about animal study, it's the invasive method. All right, so they apply the direct current directly to the brain. It's not the same as animals. It's not the same as human study. So at that time, when what this study tell us, in that time, for example, if you can see in the line A, so this is a So this is a resting state. But when you put anode on, you can see an increase of firing rate in the neuron. Okay, and for example, when you off the anode, the activity becomes at the resting. Okay, and for example, for E, when the situation's resting in the resting state is like this, left side, and then when you put cathode on, what happened? It disappear. The activity. So from that time, we know about polarity-dependent effects of anode and cathode that induce different effect in animal. Okay. All right. So in human study, we start at around the end of 20th century. The end of 20th century by Pierre. He is a great doctor in Italy. He started to use this one is tDCS, it's transcranial direct current stimulation. So they apply it over the subject's scalp. And then they just use only 0.5 milliampere at that time and only 7 seconds, very, very short period. And they found that just only small intensity, we can change the motor evoked potential assessed by TMS. I will show you the picture later. And later on, in two years later, Nitsch and Pollutz from Germans, they confirmed the results in animal that tDCS also induce different effect. It depends on polarity use, anodes or cathode. Okay, so this one is a picture to show you how they measure the motor evoked potentials. Maybe some of you know TMS before, but TMS is another brain stimulation technique. So when they apply TMS here, we can record the activity of muscle contractions by EMG. And then they use TMS to evaluate the effect of tDCS, all right? So what they found from Nitsch and Pollutz, what they found is very interesting. They found that this is a pioneer work of tDCS and it's become popular until now from that study. Okay, so if you can see the number in the table, big number, represents a great change of motor evoked potential, big MEP. So they measure MEP like this, so the size peak to peak. So the MEP, big size represent greater cortical excitability, but small size represents smaller size of MEP represent lower excitability, all right? So at that time, they would like to change the motor cortical excitability. So primary motor cortex actually is located close to C3 and C4 here. It's a primary motor cortex. In that time, they would like to change the motor cortex excitability. So they try to put 2 electrodes around the cortex to see that which one is better. All right. So what they found that when we put anode or cathode, which we call active electrode, the active one that we expect to have the polarity, the effects, you put it on the motor cortex. And then you put another one that would be reference electrode over the contralateral area. So if you can see C3 and MP2 here, so when they put anode, they will have big greatest MEP size compared to others. Others mean they try to apply electrode over O3 and CT2, O3 and FPT, and etc. etc. They try to change the position to see which one is better. And they found that this is the best positioning to change motor evoked potentials. That's why today, in most of study, we place the electrode over the area of interest, and then we put another one contralateral at the contralateral site. Sometimes people put it extra fixed montage, like they probably put it in the shoulder, something like that. But need to keep in mind that the active one should be applied over the area of interest. Okay, from that study, it's the pioneer study. They also found the after effect after 1 milliampere of anode and cathode, and they found that it's a polarity dependent after effect too. It means that if anode can increase cortical excitability, the after effect is like that. And also for cathode, if cathode decrease the cortical excitability, the after effect is like that too. But again, you need to keep in mind that it's a limit at 1 milliampere. I will show you after what happened later. And also, they also study about the current intensity and stimulation duration is a dose response effect. So for 1 milliampere, they found a linear effect. So it means that when you increase the intensity, you get more effect. And when you increase the durations of stimulation, you can get more effect too. Either anode or cathode stimulation induce, even they induce opposite effect, but they have the dose response effect at 1 milliampere the same. All right, but later on, this I would like to highlight because some people don't keep this in mind, because today the recent study showed that we probably have non-linear stimulation effect. So that is a study. So this study, as I tell you, Nietzsche and Paulus, they are the pioneer study, the first people who investigate the effect of tDCS. But the people that I cite them here, they are from Nietzsche laboratory too. Okay, so they found that with cathode tDCS, if you increase the intensity to 2 milliampere for 20 minutes, you can enhance the effect, enhance the cortical excitability instead of inhibitions. This one you need to highlight that, okay, cathode is not always decrease the cortical excitability, but with such intensity and durations, it might enhance the cortical excitability. But for anode, what they found that, okay, with current intensity from 1 to 3 milliampere, you can induce an enhancement of cortical excitability. It's still linear, but But something needs to be noted, because, okay, have a look at the second one. They also found that at least 26 milliampere of anode tDCS, only 1 milliampere. At first you induce a positive effect, but you may have a reverse effect for the after effect. They just published it last year. This is just a recent one last year, but please note that the study was limited at 30 minutes. I'm sorry, 30 minutes. So from 26 probably up to 30 minutes, after effect of anode tDCS may be not as you expected. All right, so that one should be net. And if you have a look at this one, the upper study, this one, and they also found in healthy subjects that cathode, they test different intensity, 0.5, 1, 1.5, and 2 milliampere. They also they found that 1 milliampere you can have a decrease of cortical excitability, but maybe not in case for 1.5 and 2. So this need to be highlighted. But again, these studies were done in healthy subjects only, and they are all young, under 40 years. Okay, so you need to keep in mind that if you study in these populations, they are probably non-linear intensity dependence effect, right? Okay, so I'll talk a bit about mechanism underlying tDCS. So we can separate into two phases. The first phase is the acute effect. So actually, have a look at the pictures on the right-hand side here. Actually, the resting membrane potential is about -70 millivolt, right? But with anode or cathode tDCS, this would shift the resting membrane potentials. Anode would shift the resting membrane potential close to 0. And then what's happened next? So the neuron is easy to be excited. You depolarize the resting membrane potential. So the neuron is easy to be excited, and then after that, if you give training or something like that after, it's maybe easier to improve, to enhance the cortical excitability. While for cathode stimulations, it shifts the resting membrane potential far from 0. So you hyperpolarize the resting membrane potentials, all right? So you need to remember that tDCS does not directly modulate the action potential. The tDCS just shifts the resting membrane potential. That's it. This one is a good point because in theory, it cannot induce seizure because it cannot directly induce action potential in the brain that shifts the resting membrane potential, all right? So the acute effect, there is no modifications of GABAergic and glutamatergic interneuron in this phase. But for the after effect, yes, it's different. There is a modulation of GABAergic and glutamatergic synapses to and then both anode and cathode stimulations can enhance or diminish LTP or LTD, which is correlated to cerebral plasticity. I'm not going in detail on this because it takes a long time, but you need to keep in mind that this tDCS does not directly modulate action potentials, all right? But the GABAergic and glutamatergic synapses that involve in after effect, this you need to be careful about the medications or so impact on GABA and glutamatergic, etc., because these can affect on tDCS effective. Okay, next, as the physical parameters of tDCS, and you can see in the pictures, actually, we have different size of electrodes, actually, but the standard size is about 25 to 35 centimeters square as a standard one that people use it a lot. And actually, the size of electrode also impact on your results. I will tell you why after. And it's the focality. Someone may know that tDCS is not focal at all. It's not focal. It's a disadvantage of these stimulations. And you can see in the functional MRI here, they apply the tDCS just 1 milliampere for 21 seconds over the left side of the brain. Left M1, left primary motor cortex. So you can see on the left side that you have like small dots, yellow dot here. But after they also found that on the left MSMA or right posterior parietal cortex, you also have you can see in functional MRI that the effect, the current density is not localized in underneath the electrode, but they go far away even for the another side of the brain. Okay, for the current density, for the modeling study suggests that the regions that the highest current density, it is under the electrode. You see the red color represents highest current density. So under the electrode, you have highest current density, and this would this area would probably maximize the effect of tDCS. Okay. But this one is very interesting. This is the fMRI study too in normal subject. They use tDCS, apply as the standard applications. You apply over primary motor cortex, and another one is a reference, apply contralaterally on the orbital, supraorbital area. And if for someone who not familiar with this, so the red color represents the highest density, all right? And the blue color represents the lowest current density. And what they found that if you can see in the ventricle here, I'm not sure that you can see it in the ventricle here, you see the red or orange color in the ventricle. And also, like in the cortical area here. Okay, I will use a pen. Here, and also here in the ventricle, you found the high density. So this one tell you what? It tells you that tDCS apply just over the cortex can, the current can reach the superficial and deep structures also. But the strongest signal they found near the CSF. So that's why they found a lot in ventricle. So as you can see here that under the electrode, you find the high density, and also the area that's next or close to cerebral CSF, cerebral spinal fluid. Okay. All right, this study just published this year. It's very interesting. They try to find the inter-individual variability between subjects. Some people can have better effect of tDCS, but some are not. they try to investigate that which factor that would influence on the tDCS effect. And they found that the anatomical factor, like a thickness of CSF, because you have a space, right, between skull here and brain, you have a space that contains of CSF. And also the electrode to cortex distance is the distance between electrode to cortex is also a factor that influence on tDCS effect. So from this study, they try to tell us that for people who have more more CSF thickness, or you have more distance between electrode to cortex, you probably have less effect of tDCS compared to those who are not. All right, so this is very interesting and just published. Okay, let's have a look at which area that tDCS can go through. Remember, tDCS cannot pass the free space regions. No. That's why when you apply tDCS, you need to firmly attach the electrode over the skull. If there are any free space regions, the current cannot pass through. All right? It can pass skin regions. Yes. Skull, yes. CSF, yes. As you can see in the fMRI study, gray matter, yes. And white matter. Gray matter is very important because we hope that it can reach the neuron. So, it's located in gray matter. So at least you can see that tDCS is with very small current intensity can reach brain structure, right? Okay, so next, have a look at the electrode placement. So you need to know where you would like to stimulate in the brain, the brain target, and you would like to excite or inhibit that target. You need to know it first. And then you put that electrode over the brain area. And you can find where you should put the reference. But as I told you, the original one would be one, this side reference would be another side like this. Okay. And actually I work a lot with neurological patients, so I mostly focus on primary motor cortex, which is C3 and C4. But for you who are going to do the cognitive research, you probably focus on DLPFC or dorsolateral prefrontal cortex, which correspond to F3 and F4 in 1028 system. All right, let's have a look at safety a little bit because it's a very important questions that your participants and your subject probably ask you. Okay, so this safety report, they are from stroke patients, but I think it's the same in healthy stroke and other people. So tDCS cannot change the heart rate, blood pressure, and oxygen saturation. But most, we can see that tDCS can induce cutaneous sensation. The most is stinging, itching here, or burning sensation. Yeah. And they probably have headache during tDCS also, but it's mild headache, not much. I personally see people who have headache, but after 24 hours is recovered. And this one I found so authentic is sleepiness. they can get more, you know, they need to go to bed during stimulations. But please, you need to keep them awake. Don't allow them to sleep during stimulations, because the neuron will be, you know, asleep or so. It's better if your participants is always awake. Okay. And fatigue, that's not skin redness. Actually, the skin redness I personally found a lot in Western people, not in Eastern people, because they have a white, you know, white skin, sensitive skins, and you need to tell them before, because someone, you know, have very, very red skin after that, but you need to tell them before. Okay, let's have a look at the safety dose we use in research. Actually, we start to use from for the current intensity from 0.5 to 10 milliampere. But nowadays, people try to find out that if 3 or 4 milliampere would increase the effect, but it's done in field study. And for the durations, it's length from 10 to 40 minutes, and section 1 to 40, and electrode size is not more than 36 centimeters square. Okay, current density, I will tell you after that how we calculate it. All right, yeah, this one. This one you need to know also when you read a lot of papers, you will see that they use the different tDCS parameter. They probably use 1 milliampere, 2 milliampere, difference duration, etc., etc. So we can compare the total charge density from, you know, among studies. So what that we need to calculate? So we need to know the electrode size first. So that's why I tell you that electrode size is also impact on your results. And the current density, a current first, and then you will have current density from this formula. And then you need to know the duration in minutes. And then you will have charts. And then you can calculate the chart density. And the last one that you would have to calculate is tDCS sections, the number of sections. So at the end, you will have the total charge density. So that's one if you publish tDCS today, it's better to give the total charge density in the paper too, so people can find out that, okay, compared to the others study, what the number of total charge density that you use. Okay, so compared to other brain stimulation techniques or RTMS, or as I show you in the picture first, that TMS we use to measure more the evoked potentials, and this method is very useful to stimulate the brain. But the different thing is TMS is directly induce action potentials in cortical neurons, which is not the case for tDCS. This one is a big difference between tDCS and TMS. All right, and TMS can induce a limit area, very focal. It is very focal compared to tDCS. Okay, this is a summary comparing TMS and tDCS. So tDCS is direct current, while RTMS is a magnetic. And mechanism, tDCS can change resting membrane potentials, while TMS induce direct reaction potentials. But both techniques can enhance or decrease cortical excitability at the same thing. All right, they both can induce pulse effect and is non-invasive. But for the safety, as RTMS can directly induce an action potential in the brain, this is a precaution for the risk of seizure. Even it cannot directly induce action potentials in tDCS, for tDCS. This is also, precautions. Also, when you include the participants, you need to ask if they have a history of seizure before or not. But my colleague have done tDCS in people with epilepsy, but they use cathode stimulation that they found that it's safe. All right, localizations that I show you that tDCS can induce wide area, not focal. Why for is not the case for RTMS is very focal. This one is an advantage of RTMS. Pain-free, now not pain-free. The price is friendly compared to TMS, like very friendly compared to TMS, I would say that. And size is portable that I show you that you can carry it with you. And shams is easy to shams because with sham stimulation we can give the stimulations, the intensity, or maybe just less than 1 minute to give the sensation to people, and then you stop the stimulations. Because from the niche study, the pioneer study tell us that you need at least 2 minutes to induce an after effect. So if you would design your sham protocol, you just give the stimulations to your participant less than 2 minutes, okay? But for TMS, it's more complicated. I'm sorry, but I'll go back to the questions after my talk, okay? I will finish this before because I see that someone is typing the questions. And this is HD of tDCS. I don't have this one in my lab. I think the price is quite it's expensive, but it's more focal. Nowadays people use HD tDCS, but most of them still use conventional. We call conventional tDCS, but for the HD they claim that the effect is more focal. Okay, how to measure tDCS effect? I like this photo a lot. This picture a lot. It's come from the study in 2018. Actually, you have many or several technology or outcome to measure tDCS. tDCS is just an intervention. You cannot use tDCS as a measurement. Okay, so let's have a look at the picture here. You see when you apply the electrode over the cortex, you will find the current flow intensity or electrical field in the brain first. But this one you can measure with like a modeling study, current for modeling, or computational neurostimulations. Only this kind of measurements is available to measure current flow intensity in the brain. But after that, when you induce electric field in the brain, what happened after? You can modulate the membrane polarizations, right? So when you modulate the membrane polarization, how you can measure it? You cannot do it in human. You can do it only in animal study because you need the intracellular recording. Okay, so this step you can not do it in human. However, when the membrane potentials is depolarized or hyperpolarized, what's happened? The cortical excitability would be changed, right? And after that, it would induce synaptic plasticity. For this step, you can do it in human. You can use a lot of technology that you have. TMS, you use TMS and you measure motor effort potentials. You can also use EEG to evaluate cortical activity. You can also use imaging study, all right? fMRI, for examples. This one, when the cortical excitability changes, not only one cell, it's a network activity change, right? And then this would change, it would probably change the cognition or behavior or motor performance, whatever. This one you can measure by behavior or clinical measures that's available in the clinical use. But keep in mind sometimes you probably found that, okay, the MEP changed, but the clinical outcome does not change. Keep in mind that it's probably not always in the same directions. You know, it's probably just it's a change at the excited synaptic level. You maybe found something at synaptic level, but not for behavior level. Maybe it's not enough to change cognitions or behavior. All right, so keep in mind that it's not always the same. But at the end, our final goal, we need to change the cognitions of behavior at the end. So this is our goal. All right. So I still have 15 minutes for tDCS applications in cognitive psychology research. Again, so this is not my expertise, but that I review for you that, okay, for rational, as you may know, some of you may know it already, that there's an impair of frontal cortical activities in people who have cognitive impairment. That's why we will use tDCS, because we can use tDCS apply it, for example, over the LPFC in people who have problem with cognitive functions, for example. All right, so this is a summary of electrode positioning that I find it for you today, that people used to apply tDCS electrode where's the most, where the popular ones. Actually, the popular one is DLPFC. You put one at the DLPFC and another one contralateral size, as suggested by Niche and Perlus in 2000, all right? And some people, like, if they probably would like to measure visual working memory, they probably apply over the parietal cortex. And for the executive function too, you can apply over the LPFC, and also the inferior frontal gyrus too. It's not quite far, you know, it's a frontal lobe. And you can someone also apply over primordial cortex to improve executive function too. Very interesting. And also for the language learning tasks, there are also a study apply on learning area too. So basically, it depends that what is your target of interest. That's it. And then you apply tDCS over there. All right. So this is meta-analysis available for now that I did my best to find the meta-analysis. Okay. And yeah, the recent ones published in 2012. Okay. What I found from these 5 meta-analyses, you can see the number of study here, there are a lot, quite a lot. Some of them are like 42, 52, 63, it's quite a lot. But what we found, okay, let's see for the first one. They include the study that use only single sections and apply on the LPFC. They found that anodal tDCS probably work for improved reaction times, but not for cathedral. They found the cathedral, yeah, maybe not a good sign. But the one that is very interesting for me is offline and online study did not influence the outcome. What does this mean? It means that you may apply tDCS and then you give them training. This called offline. But you may apply tDCS and training simultaneously at the same time. This called online. Okay, so from this meta-analysis tell us that offline and online did not influence the outcomes. Personally, when I work in stroke patients, it's not different the outcome too. It depends on your convenience, and it saves time if you apply together. But if in the clinic, for me, for example, if I do get exercise, lower limb exercise might not easy, to do during simulations. But online, offline did not influence outcome. Okay, the next meta-analysis form is a single sections also on DLPFC. They also found that anodal tDCS give the positive effect in healthy volunteer Parkinson's, people with Parkinson's, major depression disorder, and schizophrenia, but not much study in neurological people. And the third one, this is very interesting. What they found, this is a big meta-analysis in 59 studies. They found that single sections of tDCS does not enough or does not induce benefit on cognitive outcomes. So in healthy subjects. So from this one, as a very big data, from now, I think single sections may be not a good choice for cognitive impairment in healthy subjects. Okay. And also this one, next one, single sections also in the DLPFC. They found no positive effect for cathedral tDCS and anodal tDCS either. I think it's because of it's single sections, but they found some positive effect in neuropsychiatric patients. And the last one on inhibitory control in ADHD, healthy depression, fibromyalgia people, they also found a very small effect of tDCS. So from this, we can pick up something that, okay, maybe single sections is not good choice. Cathedral probably not good choice. And you can also do online, offline, whatever you want. And probably in people with psychological people, it's probably work, but the effect is not much. Okay, so this is my study. It is unpublished data. We are now writing the manuscript with my colleague. So I do RCT crossover design in 11 children with ADHD. So we give 5 sections, cathedral tDCS alone, not with training. So we found that, okay, we give them 5 days consecutively. We assess the outcome before, after 5 days, after 1 week, and after 1 month. We found an improvement of inhibitional control assessed by omissions earlier from visual go-no-go tasks. So the error decreased from 12 to 4, but it's back to 9 and 11 again during follow-up periods. So from our study, we can say that 5 sections probably not enough to induce long-term effect. But okay, they have a positive effect on go-no-go tasks. All right. Okay, this one is also interesting too, because the people, elderly people who probably have like a cognitive impairment, non-dementias, there are also a recent meta-analysis published in 2018. They tell that, very interesting, because they compare cognitive training with tDCS and tDCS alone too. And they found that tDCS alone have better effect. This is very interesting because in stroke, it's definitively you need to add training. But this meta-analysis tells us that tDCS alone on the RPFC can increase memory and language in people, in dementia people who have mild moderate dementia. And also in people with mild cognitive impairment too. But the effect is not long, as I found, because like most, actually, there are only 4 studies use single sections, but the others, they use multiple sections from 4 to 5, but, 4 to 10 sections, but still, then they not found long-term effect from this meta-analysis. And they said that it is unclear effect when combined tDCS with cognitive training, because from this meta-analysis, tell us that tDCS alone probably better. Yeah, very interesting. Okay, my last slide. What is currently needed in cognitive study today? This is the papers that are review article tell us that still we have incomplete evidence in increasing current intensity. If increased intensity of tDCS can boost the outcome, we don't know. So we need to explore more in the future research, especially the appropriate parameter used to improve cognitive impairment that we still don't know yet, that which one is better combined with training or not, or we use, most meta-analysis tell us that better you use another. But if you remember a study from niche lab tell us that, do not use more than 26 minutes, because after you probably induce adverse, you can reverse the effect probably. All right, so thank you for your attention. I hope I'm on time, but I will see for the, how can I see the question? Okay, I'll stop sharing now. And I'll go to the chat box. Wow, questions. From Facebook. Do the tDCS simulation cause adverse effects on other parts of the nervous system? As far as I know, no. Just cutaneous sensations. And with 10 years of my experience, I never seen people have adverse effects on the other parts of the nervous system. The most severe one that I found is a headache, but is recovered within 24 hours without taking any medication. But I have one of my patients, he has no hair, so he can't stand for the electrical stimulations. It's too much for him. So I can't run the stimulation in that subject, but that's it. Okay. The next question is how you can determine the durations experiments. So it's range from 10 to 40 minutes, but 10 to 40 minutes, I would like to tell you that it's a safety range today. So in study that I review, some people they go up to 40 minutes, but no one go far away from that. So that's why I say that 10 to 40 is a safety range. But in the future, maybe you probably increase the durations, but keep in mind that, anecdotal tDCS, if you increase the durations from the niche lab, they told us that more than 26 minutes you probably have adverse effect. So maybe we don't need to go up to 40, but 40 is the limit safety range that we use today. All right, next one. Regarding in the speech that this method can be used to treat the patients, can you explain clearly about it? Okay, I don't know if you're familiar with TMS. Now the FDA in America, they FDA approved TMS to use in people with major depression disorder already. It's an alternative treatment already, but not yet for tDCS. But they both can change the cortical excitability. Because as far as I know, I'm not expert, but as far as I know, depressions, in people with depressions, you have like an imbalance between the cortical excitability imbalance between two frontal activities. So if I remember, the left brain probably decrease the cortical excitability and the right is increased. So you can rebalance this by using tDCS. So people use it in the experiments a lot too, with a positive report, but not good at TMS because TMS is already approved to use as alternative use. If you don't want to use medications, you can ask your doctor that can I have TMS? Yes, in the US, it's legal now. Next one. How to, from Dr. Yang, right? How to determine the size of electrode. You just measure it, the size of electrode, right? So actually, in if you have your student card or your ID card with you now, it's not far from the standard size that we use, 25 centimeters square. And then actually, as you see that tDCS is not focal, for me, 25 centimeters square is big enough for cover primary motor cortex and cover the DLPFC. But if you decrease to 25, I use both 25 or 35, you need to calculate the total density, the charge total density, because it affects. But if you, like, for example, if I place the electrode over the primary motor cortex of the upper limb, for example, it's big enough for cover the lower limb area too, for the 35. But it depends. I also use 25 too, but it means that your participants would receive more current density if you reduce but the size. That's why HD tDCS is more focal. If you remember the figures of HD tDCS, you have a small, very small size of electrode. So you have more current density under the electrode. But for the HD, you need to, I think you need to be more expert to, local the brain area of interest. But for the traditional tDCS, it's you can do from 25 to 35. If you read the paper, most people use the same standard size. Yes. Okay, how long does the tDCS effect last? These are good questions. No one can tell it, but I give my experience. For example, if I stimulate the patient's brain for just only one section, 20 minutes, and the effect can last for 1 week with training. I mean, this is in stroke patients. I give them training for 1 hour after 20 minutes of tDCS, and after that, they come back to see me at 1 week later, and the effect is still there. But I also have experience with chronic stroke patients we give them 12 sessions of tDCS 3 times a week for 4 weeks. And then we have like a one month follow-up, 1 month after, not that at the end of the month, but 1 month after. The effect is still there too. We now follow up at 3 months, but we have not yet analyzed the data. And yeah, at least 12 sessions for 1 month, it's still there. But as you can see in the cognitive study that I reviewed it, you see that the after effect is quite small. The one that I did for 5 sessions, I still got only immediate effect, not long-term effect. Okay, so would tDCS induce epilepsy? I would say no, because it's not directly induce action potentials. But in epileptic patients, we recommend better use cathedral, not anodal, cathedral to inhibit, not excite. It can be done now much, but it's safer than TMS. That's all I can say. If it is offline, what's the best interval between active tDCS and training? I would say you stimulate. It's ready to be trained after. I always give the training immediately after tDCS. Don't waste the times between the interval times, because the effect would be higher that times. All right. If single sections is not enough, how many sections would be good? A good question. We need still more. We need more research on this, but it depends on many factors. It also depends on physical factors that I mentioned. People who have like thickness of CSF. And it also depends on chronicity. For example, if chronic stroke patients has the less effect than acute, for example. And also it depends on the parameter that you use, etc., etc. It depends on many factors. But I would say that single sessions now is not enough. I have done 5. I only gets immediate effect, not long-term effect. But the long-term effect is the one that we want, actually, because we cannot give the stimulation to them every day. No, it's not possible. That's why we tend to, very interesting. That's why we tend to combine tDCS with cognitive training. As I tell you that I'm not expert in cognitive field, I'm not sure that it would be induced or not. But from the recent meta-analysis said that tDCS alone is probably better. So, but with model training, I would say the opposite. With model training, I would say you go for model training. tDCS is just an add-on therapy. But for cognitive, it's still questionable. And okay, next questions. DLPFC control the emotional control in both depression. Yes, thank you. So my colleagues helped me that DLPFC or control emotional, or so that involve in depression symptom. That's why when we use DLPFC, you would stimulate DLPFC, you would get better effect in depressions, in people with depressions. All right. Yes. No more questions.
Thank you very much for the wonderful talk.
Yes, thank you. Okay, so if you have more questions, I'm not sure that is the Facebook Live, you still rerun it, but I think if people have questions after, they probably comment below, right, in Facebook. Share. Yes. Okay. Okay, thank you so much. And if you have questions, you can also email to vietnamhub@email.ncku.edu.tw, or you can comment on the Facebook fan page. All right, so thank you so much. Hope to see
Yeah.
you next time. And stay
Yes,
safe.
thank you.
Bye.
Thank you very much.
Thank you everyone to attend today's webinar, and thank you Dr. Wanalee to give us very interesting and useful information. So we will end our webinar from here and see you next time.
Bye-bye.
Thank you. Bye-bye.